Next presentation is by Dr. Pallavi Sarate, Red Flags of Endophthalmitis, Etiology and Clinical Presentation. She is Shankar Netralaya trained vitreoretina surgeon.
Good morning everyone. I'm Dr. Pallavi and today I'll be talking on a very important topic, that is red flags of endophthalmitis, its etiology and presentation. I have no financial interest and I would like to thank AIOS scientific committee for giving me this opportunity. Endophthalmitis. It is the worst nightmare of any ophthalmologist. So we will be covering this topic under etiology, exaggerated inflammation, what is pseudo endophthalmitis, how to differentiate TAS from endophthalmitis, and what is definitive endophthalmitis. So as doctor has already told us what are the causes of endophthalmitis, which are the causative organisms. I'll not go into the details of that, but depending on onset of presentation, it can be divided into fulminant, acute, subacute, and chronic. So more is the virulence of organism, more is the earlier presentation by that organism, and more fulminant is the course. So what could be the source of infection? As we all know, it can be of surface origin like skin, it can be from contaminated instruments, disinfectants. Few years back in a renowned institute, there was a case of cluster endophthalmitis which was caused by topical betadine solution which was put in all the patients. Conjunctival sac lacrimal area is the most commonest causative agent. Objects or materials like gloves, surgical instruments which are contaminated, that can also cause endophthalmitis. Thus, any patient presenting with pain, reaction or decreased vision in early postoperative period should increase suspicion of endophthalmitis. Many times we see increased or exaggerated inflammation on first postoperative day, like increased cells, flare, or there can be presence of fibrin. However, there is no vitreous involvement in that. So we all know what was the surgical course in that patient. So whether there was increased surgical time, whether there was tissue involvement or iris touch was there. So you know that there was some problem, and that is why this could be the reason for exaggerated inflammation. So these cases usually they respond very well to topical steroids, but yes, close monitoring is warranted. As we all know, TAS is acute sterile and inflammatory reaction usually occurs in first 24 to 48 hours. Usually cluster cases are seen of TAS. It is very important to differentiate between TAS and early endophthalmitis because both of them have almost similar presentation. So we can see limbus to limbus corneal edema, presence of hypopyon, presence of increased cells. Hypopyon is usually whitish in color because this is just inflammatory agent. So most important differentiating factor between TAS and endophthalmitis is involvement of vitreous. In endophthalmitis, there would be involvement of vitreous, and in TAS, you will never ever get involvement of vitreous. So that is the most important thing to keep in mind. Thus, TAS will respond beautifully to topical steroids. Maybe if pressure is high, you will require anti-glaucoma agents, cycloplegics, increase antibiotics if you want. And as I told before, close monitoring is warranted. So maybe you can ask the patient to sit in the OPD for a few hours, increase topicals and see how he's responding. So if reaction is decreasing, you know that there is nothing to worry. However, if you see patient in the morning and you call him after a few hours and you see that reaction has increased, then definitely it can be endophthalmitis, so that you can start your treatment earlier. Thus, if patient presents immediately on first or post-operative day, then you have to differentiate between TAS and early endoph. However, if patient was perfectly fine post-operatively and after a few days he comes with decreased vision, pain, etc., then definitely there should be increased suspicion of endophthalmitis. Sometimes patients come with increased reaction like increased cells, flare, there is presence of hypopyon, and in addition to that, there is so much of fibrin in the pupillary area that it is very difficult to see vitreous in such cases. So how do you know that whether vitreous is involved or not? Even if you do ultrasound in initial stages, before the exudation actually forms, it's very difficult to get echoes on ultrasound. So what it is exactly? So that is a case of presumptive endophthalmitis. You don't know what it is exactly. So as I told before, Close monitoring is very important, and now the question comes whether to inject or to wait. It is always better to inject earlier than to wait. So when patients come with pain, lid edema, presence of hypopyon and vitreous exudation, then you know that it is endophthalmitis. In such patients, always look at the wound margins. Is there any kind of exudation, or is there any fibrin extending from the wound towards the pupillary area? How is the vitreous reaction? What is the color of the hypopyon? So in bacterial endophthalmitis, it would be a yellow colored hypopyon. How is the wound margin? There would be presence of corneal edema. How much is the pressure? There would be exudations in the pupillary area. Definite hypopyon would be there. There would be absent red glow. Sometimes you would be actually able to see exudation from the pupillary area. There would be loss of vitreous details would not be seen. So whenever vitreous is not seen or you cannot see retinal details, then ultrasound is warranted. So as I told you before, early stages ultrasound may not show any signs, but later on you have to see signs like presence of membrane echoes or moderate reflective echoes. How is the retinal coral thickening? Is there any presence of T sign which is suggestive of worsening? So ultrasound does not only help in diagnosis but also in monitoring in such cases. Also, not to forget, not all cases are endophthalmitis. There is a term that is pseudo-endophthalmitis, such as retained lens matter, whenever there was old vitreous hemorrhage or presence of IVTA deposits. I had one patient who had presented around 1.5 months post-operatively, operated somewhere else, and I saw some exudates, and first thing which came in mind was whether it is endophthalmitis. But on detailed questioning, she told that she was a case of chronic uveitis and she was under treatment. So that was an interesting thing. Thus, any post-operative patient presenting with hypopyon along with vitreous exudation should increase suspicion of endophthalmitis. Always take patients into confidence, discuss with the relatives, especially in private practice. Use of words is very, very important. Don't call these patients along with other patients. Give them separate time, call them early. You have to be empathetic with these patients. Thus, detailed clinical examination along with investigations such as ultrasound and microbiology like AC tapping or vitreous culture will confirm the diagnosis. Now, why it is important to diagnose it early and start treatment early? As I told, why it is always better to err on the side of infection. So it is because of virulence of the organisms. So more highly virulent organisms such as Staphylococcus or Pseudomonas aeruginosa will have endotoxin inflammatory reaction, and just in initial few hours it will have lot of exudation of endotoxin cytokine reaction, and thus there will be melting of cornea or retinal involvement. Thus, even after treatment, improvement in vision would be compromised. Thus, initial first 3 hours, there occurs tenfold increase in the multiplication. That is why early treatment is important. The take-home message is endophthalmitis in any clinical presentation should be considered as ophthalmic emergency, and immediate treatment should be started. From clinical signs, you should arise high index of suspicion, and whenever in doubt, always err on the side of infection and start treatment early. Timely diagnosis and immediate treatment will definitely improve visual prognosis in such patient, and tailored approach is required in each and every patient. Thank you so much.
Thank you, Dr. Pallavi, for a detailed explanation.